end of this meeting. You should have had a message up to say the recording is now in progress. We have, how did I get an American accent there? As I said, progress. There we go, right. We have allocated time at the end of this meeting, as always, to respond to questions received in advance from members of the public. We don't have any questions today, and we have a number of members of the public signed in, 9 members at the moment. So welcome and thank you to those for attending. Please, board, can I ask you to look at the conflicts of interest register and declarations of any interest, please, relating to this agenda. None have been noted in advance, and I have none at the moment. Thank you very much. You have the minutes of the last meeting in public, which we held on the 18th of October, and the matters arising. Please may I have comments or questions or approval from board in relation to those minutes? Thank you. Noted and approved. We'll move then to our CEO, Fiona Edwards, for an update. Thank you, Fiona.
Hello, everyone. I'll keep it brief because the main preoccupation at the moment is obviously the fact that we are experiencing a huge amount of pressure as a result of a surge in illness amongst our population, anxiety about strep A, and that manifests itself in very high attendances in primary care, in pharmacies, and in our general hospitals. And I just wanted to reflect. We had, we'll talk, Neil and I will talk about it later in the meeting, just a massive thank you to the huge efforts of our staff in health and care at such a challenging time, with industrial action, the ambulance threatened action tomorrow, the action we had on Thursday. We managed to keep going in the Frimley system really well, and the commitment to everyone to respond well to our residents' anxieties and real needs has been just phenomenal going into this period. This week is always a busy week just before Christmas, but the levels of demand with the strep A concerns, and also the high levels of flu in the public and also amongst staff, has put probably unforeseen additional pressure than what we planned for in our winter plan, but we'll come to that later in the agenda. But I think for the board, it's really express our thanks to staff, volunteer partners and partners across the whole system that are really responding well. Thank you.
Thank you very much, Fiona. We're going to move now to our strategy updates. And the first part of this is the NHS Frimley Health and Care Strategy Refresh. And Sam, you were going to take us into this. Thank you very much, Sam.
Thanks, Priya. And Ollie, can I just check, are you planning to share the slides for this particular item? I'm hoping that colleagues have had a chance to look at them already, but it'd be helpful to share them for anyone joining from outside of the board. I won't spend an awful lot of time talking through the slides. There are only 3, and I want to make sure there's opportunity for members of the board to ask questions towards the end of the slot. So the first slide now, please, Ollie, if that's okay. I'm sure the board are fully aware by now of our existing ICS strategy. It's called Creating Healthier Communities. We often display it in the way that you can currently see on your screen as the rainbow diagram, which includes the 6 strategic ambitions which we set out just over 3 years ago now when the strategy was first published. The strategy only has 2 objectives. One is to reduce health inequalities, and the other is to increase healthy life expectancy. And we've been working really hard at this since the point the strategy was published, alongside the other challenges which the health and care sector have faced since the start of 2020 and onwards. We always had an intent that as the legislative and statutory architecture underpinning the NHS and social care changed, that we would come back and look at this strategy again. And with the implementation of the Health and Care Act in July 2022, that's exactly what we've set out to do. There is also a national ask for all ICSs to look at their strategy during this period, but recognising that different ICSs are in different places, that piece of work will be very different depending on which geography you are in. For us, given that we already had a strategy and that strategy has not delivered the full intent of its original aim, this is very much a requirement of a refresh rather than starting something new. We're very keen to continue doing the work through the lens of a refresh and make sure that the priorities which are set out in the strategy are more reflective of the world in which we're operating today, following almost 3 years of global pandemic and the other challenges which we know we're currently facing together. The work of refreshing the strategy and the authority to oversee the work is not held by this board and it's not held by the ICB. So this is an update, not for the board to approve, but for the board to be aware of. The statutory authority on the ICS strategy is actually held by the Integrated Care Partnership, more information of which is set out on this page in front of you. The ICP is a new construct. It is technically a joint committee between the ICB and the 5 local authorities in this geography who have responsibility for commissioning adult social care. And we have taken a very deliberate decision in the Frimley system to create a large and inclusive ICP, which we refer to as the ICP Assembly. The Assembly met for the first time in September 2022, and it met again in November 2022. In September, as I've updated to this board in the past, its main focus was on the role of the ICP and how the ICP works together. And in November, the main focus of the meeting was around the strategy refresh, hence what I'm sharing with you today. Ollie, could I have the next slide, please? Thank you. So in November, when the ICP met, we had over 50 members of the local public sector from the NHS, from local authorities, from social carers, providers, Health Watch, other voluntary sector organisations and charities, as well as members of staff as well. And we led a facilitated workshop to look at the 6 strategic ambitions and understand what has been delivered to date through the work on the ICS strategy, what has changed since the strategy was developed and produced back in 2019, and to ask the question on what do you think should be in the strategy for the next multi-year period ahead. It was a really phenomenal, generative and energizing discussion, and we collated a huge amount of feedback from attendees through a range of interactive workstations, conversations, and review following the meeting as well, where we asked attendees to be really thoughtful and honest and open around what they'd like to see in the strategy in this next iteration. You can see some of the comments summarised on the right-hand side of this slide here, aligned to each of the 6 strategic ambitions. This really is only a very small snapshot of some of the content that was generated both on the day and in the review period that followed the ICP meeting in November. The team have been working really hard over the past 3 weeks to bring all that content together and to create a new refreshed strategy document for us, which really seeks to bring all of this into the heart of the next period ahead. And we are now on the cusp of being able to share that formally with organisations in the post-Christmas period. Ollie, can I have the final slide, please? So just a really quick update on the timescales that follow from here. So I've mentioned the ICP workshops, as you can see on the top line there. We've been working throughout December on taking that refreshed content through into a new document and setting out new plans for each of the strategic ambitions. We actually decided to give our colleagues a little bit more time, given the pressures which have been described in this meeting already and how many other challenges are around at the moment, more time to actually review the first cut of the strategy. It was circulated 2 weeks ago, and we've asked for comments through by the end of this week, before the Christmas bank holiday weekend. And we will be in a position next week to either share, submit or publish as is required, although we have no information on that requirement at this current point in time. Our next formal steps will be to seek further views formally on the strategy document in its current form. We'll be seeking to bring the final draft of the refresh strategy through formal boards and committees such as this one during the final quarter of the year, and with partner organisations in local authorities and other organisations in the partnership as well. Our intention, therefore, is to bring a final version of the ICS strategy through to the next scheduled ICP Assembly meeting in March 2023. We'll be really keen to continue this discussion when the strategy does come through to the ICB board, which I expect will be in January or February. Looking forward to that conversation when it happens. And for today, happy to take any questions people might have around either the document itself or the process which goes onwards from here. Thank you.
Thank you very much, Sam. Now, colleagues, comments and questions. I'm going to put up the flag. So Graham, please.
Hi, Priya. Hi, everyone. Yeah, I just wanted to say I thought it was a great session that we held with the ICB Assembly. And I just wanted to pick up, I think, one of the things that those questions alluded to on the right of the slide, which was, I think there was a really feeling that what we've done before was still very much relevant for today. But the next layer of this strategy would be really important, where we talked about, well, what difference has it actually made to the life outcomes of the people of Frimley. So I thought it was really good, and it was really great to see that being the next day. So I guess I'm really looking forward to that next stage, which I'm probably getting carried away with myself, Sam, but that was what really struck home for me from attending the session. So thank you very much.
Oh, thanks, Graham. It's really great to hear that.
Good. Okay, so I can't see any other hands up, and I know that many on this call were part of those sessions, so thank you very much. Let's move then to our maternity overview item, and I'll pass now to Dr. Lalitha Iyer. Thank you, Lalitha.
Thank you, Priya. Thank you for giving us the opportunity to present the maternity work. So I'm Lalitha Iyer. I'm the Chief Medical Officer and also the Senior Responsible Officer for this work stream. I know that some of my colleagues from FHFT, my MVP colleagues and my PMO are in the audience, and I want to acknowledge their presence, but also thank them for all the work they do with so much of a positive energy in this area. Next slide, please. So this is what I thought would be useful for the board, and clearly at the end of this, if there were areas that you wanted us to touch on, we can come back or send you information. So what I'd like to do is give you a brief overview of how the service works, a little bit about the maternity governance within the ICS and also regionally, touch on the O'Kendon report and the more recent Kirkup report, share with you some examples of the LMNS board agenda, share with you some of the work the MVP has done, and also some of the service transformation work that we have undertaken so far. Next slide, please. So this on the right is a graphic representation of where most of our pregnant women reside. The darker the color, the red areas are where we have more pregnant women. You see that mirrored on the left in the percentages. So you will see that Slough and North East Hampshire and Farnham are predominantly the areas that feed into our maternity maternity women population, pregnant women population, I should say, predominantly, and has done consistently. If you look at the bottom left, consistently the pattern seems to be the same, where Surrey Heath is the lowest, and Slough and North East Hampshire and Farnham are more or less the same. The relevance of this is really to see how we spread our services and organize ourselves, providing care for our pregnant women. Next slide, please. So this is a little bit about the diversity of our population. So if you see the top half of the slide, nearly 73% of our women who touch our services are white, whereas about 21% are from the Asian and Asian British population. A small number of them are from the Black or Black British population, about 2.9 or so. Clearly, the spread seems to be more of ethnic diversity at Wexham Park, as you can see in the top again, with 37.6% are from the Asian population and 4 from Black or Black British. When we then looked at how do they represent themselves in people who book after 16 weeks? So late booking means that their medical conditions may not be identified. They do not access the fetal scans that are required around 10 weeks or so. And that's the importance of late booking and identifying late bookers. And we find that, again, the ethnic groups such as the Black or Black British and the Asians are higher in the late bookers. In absolute numbers, we find that the Asian mothers come up higher just because the percentages of Black or Black British women are lower. We also know that conditions like diabetes, which then lead to large babies and therefore instrumental deliveries and other complications, are commoner again in the ethnic groups, as you see in the bottom half of the slide. Next slide, please. This, I want to take you to the right-hand side of the slide here. At the bottom right, we have spoken about before at board, where we see that the folic acid before pregnancy, so this is preconceptionally women taking folic acid so that the fetal abnormalities are lower, is much lower in places like Slough, possibly lack of awareness, but also could be lack of the resource to buy these medications, which are not prescribed traditionally for women from primary care or from any other source. So we see that, and we're trying to look at methods on how we could actually make inroads into this. The top right hand talks about the stillbirth and neonatal death rates. And sadly, we know that we are similar to the national picture, where we know that births to Black and Black British mothers are almost twice as commonly affected by stillbirths and neonatal death rates, and a little bit more in terms of Asian and British Asian mothers. And again, the takeaway from here is that this has informed our equity plan. We are working with ensuring that our hubs are properly staffed with clinicians and midwives who can interact with the community in languages they understand. We're working with our MVP to understand barriers that people from these communities face. Next slide, please. This is just again to give you a flavor of our structure. For those of you who may not be familiar, we are lucky that we have one trust within our ICS. This trust has 2 maternity units, one in Wexham Park, one in Frimley Park, and both maternity units have birth centers for women who wish to undergo the low-risk birth, but not actually home birth. So both of them are really well-staffed, lovely units. And again, the advantage here is that should a complication suddenly happen in an unpredictable way within the birth unit, they are then able to access all the care immediately in an urgent fashion, and intervention in terms of medical intervention with obstetricians are available on site. We've got 10 maternity hubs, and the next slide tells you where they're located. We have 5 different stop smoking according to our places, but actually 4 of them are with a single provider, so we're able to have much better conversations now. We've got 5 health visiting services for our places, and although we have 1 Maternity Voices partnership, we've got 2 groups, one facing the north, which is Wexham Park, and one facing Frimley Park. And it pulls in representatives from the community that actually touches both these hospitals, so that we can have conversations that are really representative. Similarly, we've got 3 maternity mental health providers, and we're linking in very, very closely with other partner and voluntary organizations in our places based on the communities we serve. Next slide, please. And this is just, as I said, the midwifery hubs. So essentially, a hub is where the midwives see pregnant women and provide not just antenatal care, but other services, be it, a little bit of help on infant feeding, be it other problems that can happen, a bit of smoking cessation services, mental health services, and so on. So we are trying to beef up all the hubs to provide a holistic care for a pregnant woman as the need may be. Next slide, please. This is the governance aspect, and I've got 2 or 3 slides on this. And if we start with the LMNS board, which is at the top, just wanted to show you that the LMNS board links very closely with the Maternity Voices Partnership Board, the Trust Board itself, and we have a regular LMNS leadership safety group that meets up in order to look at the various aspects of it. As you know, the board also reports upwards into the ICS board and into all the other regional meetings, and we'll touch on it in the next few slides. I just wanted you to have a flavor of the various work streams that we're involved with. So there's a preconception and maternal health, under which sit the infant feeding, the collaborating with public health and the public sector, healthy weight and nutrition, infant feeding, and all of those kind of things. And we've got the core national deliverables on which we are constantly talking to region about. So again, the personalized care plan, perinatal equity, community hubs, as we discussed, and so on, as you can see on the slide. And perinatal quality assurance is big, and I will it's in detail on another slide. And on the left, you'll see the frequency of the regional meetings that we are linking up with. Almost every 2 months, we have a meeting with region on various aspects, be it safety and concerns or other national deliverables. Next slide, please. So this is the perinatal safety assurance that I was talking about. So again, if you start in the middle with the LMNS board, we've got the SIs and HSIB referrals. This is where things haven't gone as well as they should do for a mum, and we have had issues with the pregnancy. And we discussed this in a large amount of detail within the board. We also have started looking for quite some time on the ethnicity of these women to understand whether we are not serving this part of our population well. And there seems to be some red flags that have come up, and we are addressing it in order to see how best we can improve our services. And again, things like the training and maternity capacity, the Okendon updates, all of these are discussed here. We have Bob as our buddy, and we regularly interact with each other. We learn and share good practice with each other. Again, you will find arrows taking you upwards towards the Regional Maternity Transformation Board, where we report into regularly, as you saw on the previous slide. We're also part of the Regional Safety and Concerns Group. We report into the ICS Quality Group, and Sarah Bellas, who is our CNO, also sits on the LMNS board. So there's a lot of linkage between the quality group and ourselves. We've got the LMNS leadership meeting there as well, as I spoke to you about earlier. And let's not forget that the trust itself has their own internal safety meetings, which again feed back inwards and outwards from the board. Next slide, please. This is just to give you a flavor of who sits on the LMNS board. So you will find a variety of people into the board. And of course, if there's any subject matter specific expertise required, they do come in and out as required. Next slide, please. This is the new slide that some of you would have seen that was presented a few meetings ago about the whole LMNS structural governance, and again, the ICS governance rather, and again, you will see the LMNS board linking in upwards to the System Quality Committee, and we report into the ICB board if any escalation is required. Next slide, please. To give you a flavor of what's happening with the workforce, we know that the number of midwifery establishment actually has increased because we've had some Okendon funding, and the ICB has matched, and the trust has matched some funding as well. So we are actually much better than where we were, say a year ago, but we still have some vacancy, and we are not an outlier in this. Most trusts have vacancies, but we're doing quite well in this area. For example, we've appointed consultant obstetricians with special interests in maternal medical health, for example, but we are also working with increasing recruitment of midwives, for example, from the student midwives, but also international recruitment. And we've been commended on some of our work that we do on both these work streams by the region. Next slide, please. This is just to touch briefly on the Ockenden report. You'll all know that the initial report was back in December and a full report was published in March. Now, it consisted of 7 immediate and essential actions, but beneath that sat 128 questions with various assessment criteria. And these are reviewed regularly by the Trust, but also by the LMNS, and we had to submit regularly to NHS England. And this is a complicated template. It was a huge exercise because it's not about just filling a template. It's about providing evidence, holding oneself to account. And when we started filling this, I still remember that we were commended on the way we were providing evidence. And one of our consultants from FHFT shared the technique and the method in which they were gathering evidence so appropriately and sharing it with everybody. We recently had a team visit in August 2022. I think Sarah alluded to this in our previous meeting as well. And the report has been shared to the report will be looked at in detail at the LMNS board and with the quality committee, and any concerns will be escalated to the board. But overall, it was quite a good report as an initial read. Next slide, please. So this is just again to give you a flavor of how the templates look and how complicated it is. And when the Ockenden visit happened in August, the Trust, in a transparent manner, downgraded themselves on one or two questions where they felt that because of EPIC, which is a new computer system that they were dealing with, they were unable to constantly ensure that the audit, which is part of the evidence, was not possible. So if you couldn't audit it, then really, even though you were green and you could audit it before, one needs to be honest and say we couldn't audit it, and therefore they downgraded themselves to amber. And in fact, the region applauded us on this and appreciated the fact that we were constantly looking at it. Next slide, please. So this is a little about the Kirkup report. So Dr. Bill Kirkup took up an investigation which was review of care for over 11 years. In East Kent, it was about maternity services, so that for the future maternity services, that the care could be provided in the right way with the right standard. Next slide, please. Unlike Ockenden, which is more about compliance, this is not really about compliance. It was a distressing and difficult read, and it was more a list, more a bit about the culture and the organizational aspects around cultures. And really, everybody agrees that this is not a maternity report. It should be identified as and highlight working across all NHS services, whether you're a trust or any other provider. And it's about how you hear information from the patient, from outside organizations, and how do we tackle poor behavior, ensure high standards, and how do we at a board toward oversight ask the right questions to provide care in the most optimal way for the people touching points where they need our care, not just in maternity. Next slide, please. And the report essentially identified 4 areas. It's about identifying poorly performing units. How do you give care with compassion and kindness, and work as a team with common purpose, and responding to challenge with honesty. And I think honesty and integrity comes up quite a lot. Next slide, please. So we are awaiting further NHSE guidance to progress the recommendations sometime in early 2023. And it's expected that this report will bring along actions from the Ockenden report, the maternity transformation deliverables, and the long-term plan, and all of this together. And when this comes to us, certainly we are happy as a team to come to the board and to update this board. Next slide, please. And this is just, again, as I said right at the start, an example of what happens at the LMNS board. We meet 6 times a year, so almost every 2 months. We need to meet about the safety aspects of it at least 4 times. So we spend 2 meetings in the year on transformation. So in December, we spoke about the transformation of services, but also about Ockenden and Kirkup, which was very timely at that point. Next slide, please. So this again is an example of what we need to submit in January for governance purposes. So it tells you about the various things that we have to send returns on. In January, I think, is a particularly busy month for our PMO and our team with maternity. Next slide, please. So this is the Maternity Voices Partnership, which is one on each side. They meet up regularly. They also meet up with staff for feedback from the patients. So it's not just listening to patients, but they actually give feedback back to the staff in order to make a difference. The NED, who sits on the trust board, meets up with the MVP, and you get a flavor for the volunteers. And we were about 2 years ago, I think, at a stage where we did not have enough representation from the ethnic groups, and we've gone out positively encouraging attendance, and now we're really pleased that at least half of our MVP has adequate representation from the BAME groups. And the kind of things they work on is, you can see on the slide, from infant feeding to social media stuff, and they do have support from creative designer as well. Next slide, please. So last but not the least, the service transformation and service developments. Mama's Line is now, other systems are looking at us and want to emulate what we've done. It's a seminal piece of work where actually our midwives are sitting in the SCAS center at Bicester, and they are providing a single contact for women from within our ICS. So anybody registered to book here can call this number from 16 weeks to 28 days postpartum. From April, they've taken about 17,000 calls, and 3/4 calls are answered within 60 seconds. They have an immediate language line, a translation service available, which is really good. What they also started doing from June is supporting the SCAS staff itself. So if there was an ambulance that was dispatched to a pregnant woman with a problem, they were able to then talk to the woman as required, and they step down a few ambulances, but also support the woman until the ambulance crew arrives. So it's been a real work of collaboration, appreciated by the SCAS team and also from our midwives who provide the service there. They love working and providing this service for women, and feedback anecdotally is really great, and they are planning to do a official survey on feedback. The Forget Me Not service is about anyone who has a pregnancy loss before 24 weeks of gestation. Again, we had some national funding towards this, and this was a gap that we identified as we heard from patients and from professionals, and that's why this service was established. Next slide, please. This is about pelvic floor. We know that as one has a baby, it comes through the pelvic floor, and any woman who has gone through a birth can have a really poor pelvic floor with poor outcomes for their bladder function and for future pregnancies and deliveries as well. So what the team is doing, this is again new, and this service, the AHP providing this service was actually one of the nominated finalists for this Chief AHP Officer Award as well. So women are graded into low, medium, and really at high risk for pelvic floor dysfunction when they get pregnant, and they are then signposted to help or seen regularly so that they come out of the pregnancy with pelvic floors that are not really damaged, giving them future problems. So that's again a service that is really well appreciated by women. Next slide, please. Yeah, this again is just to remind all of us and you that the perinatal equity work was a large piece of work that was conducted. Many of you heard about it. We had great engagement from the matrons, the MVP, the staff from the BAME groups in the trust, and our own EDI leads, our ICB staff, all of them inputting into this. And this local maternity system perinatal equity strategy is on our Frimley Health, on the Frimley Health and Care ICS maternity website as well, for any of you who may want to access it. We have shared this at many regional equity meetings. Next slide, please. And last but not the least was just to touch on the fact that we are quite conscious about the ethnicity of the staff who serve our pregnant women. And there is some evidence, good evidence to report that workforce that mirrors the population they serve has better outcomes in terms of mums feeling more reassured, and also in terms of actual outcomes in terms of how the neonatal baby does. So you'll find that the population is in blue and then the maternity staff is in green. So if you look at the white population, we have a lot more white staff compared to the women. Whereas if you look at the Asian population, there are less staff from the Asian population compared to the women who touch us. So there seems to be an underrepresentation of the BAME population. And we are focusing on our workforce and recruitment in order to address all these outcomes. Next slide, please. So this was a whistle-stop tour of everything in maternity. What I haven't touched on is that there is a lot of digital work that is going on with My Frimley Health app. There's a personalized care plan app that is being launched as well. And we are doing a lot on the healthier eating and folic acid prophylaxis for women as well. Priya, I think I will stop here.
Thank you very much, Lalitha. Thank you. Right. Comments and questions. Look to Rachel, please.
Thank you. That was really, really helpful, Lalitha. There was a huge amount of information available to us, and I really appreciated it. Lots of insight. You mentioned in passing home birth, and that was the one thing that didn't get elaborated further in the slides. And I wondered whether there was any other commentary that you might want to add about the home birth provision for this community.
Yeah, so we do have home birth provision. Clearly, if you're really high risk, then you're encouraged not to have a home birth. We do have quite a low rate of uptake of home birth, about 2% on the Frimley Park side, 1% on the Wexham Park side. Now with the industrial action, with the ambulance staff strike coming up, every woman who's booked in to have a home birth has been personally written to suggest to them that although the midwife is available and the midwife will go to their house to promote a home birth, it may not be the best option, especially as obstetrics comes with unprecedented, unpredictable problems. And if the woman then needs a transfer into secondary care, that then becomes really difficult if the ambulance staff are striking. So they've been given the option of coming to the low risk maternity birth units that both sides have as the better option for them. But clearly the choice still finally rests with the woman.
And if I may indulge myself with a follow-up, Priya, is there a sense of whether there is any gap? So is the level of home birth uptake equal to the expressed desire for a home birth, or is there any gap between what women are wanting and what they're able to secure?
So I guess one of the things that we discussed when the Okendon regional team visited us was that whether we should broaden the group to which home birth may be available in terms of the medical risk that one carries in pregnancy, and that should that discussion be had anyway. So we are taking that up as a point to look at, to compare ourselves with other neighboring ICSs, LMNSs as well.
Thank you.
Sorry, thank you very much, Rachel. Thank you, Lalitha. Real thanks for all the work that is going on and for all those involved. This is touching a lot of our teams across the system, and this is really very good to see. So thank you, everybody, for the work, and thank you, Lalitha, for presenting today.
Thank you. Thanks a lot.
We're now going to move to our winter planning and the urgent and emergency care update. So over to Fiona Edwards and Neil Dardis. Thank you.
Thank you, Chair. Have we got the slides available to put up? Yes, brilliant. Okay. All right. So we've got yet another set of slides to go through just to structure our input. But clearly, Sam's going to help us as well, because he was involved in some of the original commissioning of strategic work that we did in the summer, that has put us in a relatively strong position, but that position now being faced with the unprecedented surge in demand that I reflected on right at the beginning of this meeting. So if we just talk about the context, the next slide, please. So this was the data at the time of preparing this presentation. It's probably even higher in terms of figures around what we're facing across our urgent emergency care system. And it's really important for us all to think about the urgent emergency care system, not as a silo sat on the side of other bits of the system, but almost as the result of joint working, system working in every aspect. And you'll see this reflected in our programme of work. So when we talk about challenges in different parts of the system, they are reflective of underpinning saturation and capacity issues driven by increased demand and surge from our residents, and also workforce gaps in social care as well as in health, driven by a drop in workforce numbers and numbers of vacancies, but also at this moment in time with winter being affected by all the flu, colds, COVID that we are all facing, as well as citizens and members of the public. So systems challenges, just to call them out, we have seen since 2021 an increase in GP appointment activity, people of 10.5%. 16% more GP appointments provided than pre-pandemic, despite a shrinking workforce, as I alluded to, and 10% year-on-year increase in GP activity, and also an increase in call to 111. And then that manifests itself, and the challenges in terms of our emergency departments are higher than the 6.9% of the 6-week average now. Certainly the last 2 weeks, they've continued to rise. And at the point of time of reporting this, we had a 33.8% increase in children with their families attending emergency departments. And on some days that's been 50%, close on 50%. And these departments are designed for, say, well, Neil will be able to tell you, but we're getting 3 times the numbers of people that are safe to manage in our emergency departments in terms of Frimley Park Hospital, Wexford Park Hospital. But the staff are doing fabulously well in responding to that. The big challenge for us, which is a real manifestation of our length of stay challenges in the hospital, is the amount of time people wait in emergency department to be admitted once they've been checked and assessed, which is hovering between 13 to 20% of people waiting for more than 12 hours. And last night, it was the worst ever, going up to 20 hours. The surge, has been the highest ever. So that's a pre-Christmas, but also the compound effect of the other surges that I've at the moment. That's what all our efforts are designed to respond to now. So we're in a collective high incident, critical incident mode across the Frimley system to respond to that. And then we've got the ambulance strike tomorrow to be able to mobilise and make sure we can respond to the people that are most in need of an urgent response. So that's a very here and now pressure. But I'll go back to the what we're trying to do for the medium to long term as well as the short term and that framework. But I'll hand over to Sam just to describe that process in the next couple of slides. Sam.
Yeah, thanks, Fiona. Just a couple of quick slides from me. So, and members of the board will have seen elements of this in the past, so please regard this as a bit of a refresher. When we met in October, we spoke about the UEC review, which we undertook over the course of the summer. That was a whole system review, working in partnership with not just the providers of ED services, as Fiona says, but with actually all parts of our health and care system who provide on-the-day care to residents and to patients, but also the longer-term drivers which affect people's health and their likelihood of requiring on-the-day care into the future. Over the summer, we worked with colleagues, over 130 of them, through interviews, stakeholder events, other listening events and conversations, to understand people's lived experience of both working with and accessing urgent and emergency care services in the Frimley system. We also combined this with data analytics and insight, which was generated from our analytics platform, to ensure that we could triangulate those stakeholder interviews with good, solid data, which tells us about how people are accessing our services and how demand has changed, particularly over the period of the last few years, some of which you've just heard about from Fiona as part of that framing of the challenge. We also looked at a number of other benchmarking pieces, international and national best practice, to inform a set of recommendations for this organisation and its partners to look at for how we could make longer term, more strategic and structural change to how we deliver urgent and emergency care services to the population and other services to ensure that people need urgent and emergency care support less going into the future. We've come up with a range of interventions. We have 32 in total, and since the board met in October, our UEC strategy group has met to look at those 32 and understand how we would prioritise them and bring them forward into a programme of work in the new year and beyond. So that's the overarching long-term approach to change into the medium and longer term period. Ollie, could I have the next slide, please, just for a touch more of the detail? Thank you. So we really want to hold a discipline here of separating the immediate priorities of things which we can change now to bring additional improvement and sustainability this winter, support to our residents and our services. You'll hear more about that in a moment when we look at the winter plan and the activities that have been undertaken as a part of that winter plan. But keeping that very separate from the medium to longer term actions which we can take, which will provide greater sustainability and improvement in the years ahead. I mentioned a moment ago the Urgent and Emergency Care Strategy Group, which was implemented and had its first meeting during November. That's clinically led. It's co-chaired by the medical director at Frimley Health Foundation Trust and Dr. Hugh Thomas, who's a member of this board and in this meeting today as well. We collectively and unanimously agreed in that session with some very initial prioritisation around looking at minor injury and minor illness services. And we've established a task and finish group around that particular piece of work to report early in the calendar year back to the strategy group. But in a more longer term sense, the rest of those 32 initiatives are being examined and scoped and put into a longer term piece of work to create that sustainability piece far into the future. I won't say much more than that, I don't think, Fiona, so I'll hand back to you. Thank you.
Thank you ever so much, Sam. Ollie, next slide, please. So our winter plan, which also is our framework of work stream for our beyond winter, has 8 work streams, and the first 4 of those are in the blue boxes that you can see on the screen. And then there's an overall underpinning comms and engagement piece around all of the 8 work streams. So the first 4, community transformation, which includes building capacity and investing in urgent and community response and getting that fully functional, with 86% of patients being seen within 2 hours in the community. We've developed and are setting up 5 virtual wards, which is equivalent to 91 beds additional capacity, being fully operational across frail, elderly and palliative care. So we have the voluntary sector supporting us in the hospice movement with the palliative care virtual wards there. And then also, in addition, our clinical lead has been seconded to support the region's work in this virtual space. But that's live and is part of our increased capacity to deal with the challenges. Then we've got proactive management of high risk, patients, which includes supporting up to 20,000 complex and frail patients and care home residents using remote technology to help prevent admission and help people manage their health and the homes that they might be living in terms of residential care, support them. And we're rolling out remote monitoring to care homes at this moment. It's just started with 10 out of 135 homes being up and running, isn't it, Sam, I think, at the moment. And we're on track to ensure 5,500 patients are onboarded by the end of this year as part of our capacity building. Our third work stream is primary care transformation, which is we've already allocated an extra 1.2 million to support the identification of 60,000 primary care appointments over a 20-week period. So that's capacity, again, in the context of a reduced GP workforce. So again, it might be increased capacity, but it does put more workload burden on our existing GP workforce. But people are working with that and focusing on enhancing our capacity to respond to respiratory presentations and conditions. And then we have a piece of work which is critical, which is the transformation of same-day access in primary care. And that's both working within our 5 places and across our 16 primary care networks in partnership with our secondary care providers, which is really critically being overseen by that urgent and emergency care strategy group, which Sam alluded to being co-chaired earlier. And then we've got currently running 2 GP streaming sites at Wexham Park and Frimley to try to reduce the burden of attendances. And so we have our GP commission services working in space alongside bang next door to ED and being able to see whoever they can that really don't need to be seen by emergency clinicians. So then moving to the next slide, and then I'll hand over to Neil. There's on this slide, the other 4 work streams include operational capacity improvement. So that's the focus on length of stay. And we've got specific pieces of work which you can see alluded to, such as community capacity and care homes liaison. And the trajectory for these bids that we've kind of built in as part of our winter plan is an additional 27 beds per day, which will rise during this period to 96 per day for January to March. So then the additional discharge capacity. So you will have heard about the National Social Care Discharge Fund, and we have 45 schemes identified with partners, which we have submitted for to access those funds and to generate additional capacity equivalent to 54 additional beds, which is how the NHS thinks of capacity across urgent emergency care. And then our other 2 critical work streams are children and young people and mental health. So we've got a few things. We've got a clear children's paediatric cell has been rapidly set up to ensure coordination and response, particularly in relation to the Strep A concerns between secondary and primary care clinicians. We've developed a resource bank around cost of living and fuel poverty, and we're working with housing to identify opportunities to support schemes that address damp and cold as an example of that cell's work. And then in mental health, the work is ongoing and developing around safe havens and crisis and resolution home treatment and support there to enhance. But again, continuing to try to identify further responses that could help with the capacity surge or the surge in demand and capacity, particularly across children and adults' mental health services. So I'll stop. That's the 8 work streams. and some of the plans for trying to build capacity, but also create different ways of working. And then we tried to test all of this with our multi-agency discharge event last week that I'm going to hand over to Neil to describe and share reflections on.
Thanks, Joan, and thanks, Sam. And I think, linking that point back to the point around the strategy refresh, I think it shows, when we approach the strategy, some things have changed beyond all recognition from when we developed our initial strategy. And I think the work you just described there, Fiona, shows the work that we're trying to do to readjust, to get our services to where we want them to be. I mean, Fiona, you invited me just to kind of colour the challenges around some of this. I mean, pre-COVID, some of our, the busiest days in our EDs would have seen about 350 attendances coming through one of our ED departments. And over the last couple of weeks, we've seen record numbers in excess of 470 through each of our emergency departments. So that just gives a sense of, I think, the scale of increase, coupled also with then what you see is a lack of flow. So the emergency departments are built for usually about 80 to 100 patients. And we at some points have seen 200 patients in the departments at any given time, which means there isn't space for our teams to see patients, which causes these extended waits. And that flow compounded by the fact that something in the order of 20% of our beds in our hospitals, despite the fact of having an extra in excess of 100 beds open, are sometimes filled with patients who could be being managed elsewhere. So a system, as you described, Fiona, that absolutely isn't flowing in the way it should be. So I think you've described really comprehensively the work we need to do to get this our services into a space where they're sustainable and delivering the care we want to provide. But as part of that, we recognise that we need to take some immediate actions wherever we can. And we held a week last week, bringing all partners together to really try and focus all of our attention and our resource on any immediate improvement we can make in advance of the Christmas and New Year period, and particularly around building from there some learning around some ongoing improvement work that could be made. And I think there was a real sense of enthusiasm and partnership in that work. It was great to see teams come together so positively to really want to make an impact and improve care. And on this slide there, we highlight some of the areas we were trying to focus that improvement work and really try and make an impact on those areas that were within our gift. And I think it's fair to say, we did see improvement in each of these markers. I think we saw improvements in reducing times waiting for pharmacy drugs to support patients to be able to be discharged. I think more on-site presence from colleagues in social care and other agencies really helped teams working in a multidisciplinary way to improve communication. We undoubtedly saw the improvement in some of the investments we've made in some of our digital technology that removed many blockages and delays that we often see in pathways, and focusing our senior clinicians around this one endeavour, I think really saw us able to make some improvements around flow. Sadly, some of that was offset by, as I say, some record numbers in terms of demand and really exacerbated by some of the challenges that we're seeing and have been described across the system. But no doubt we'll take the learning for the improvements that were made last week and hope to sustain those through the course of the winter moving forward.
Thank you. Thanks, Neil. And then the last slide just reiterates what I was describing earlier, that this is all wrapped up with a comms and engagement approach that we're adapting and developing all the time we've learned a lot from the multi-agency discharge event last week, but you can see that we've reached out. The use of the app, I can't remember, there was a phenomenal figure of access to the app, particularly around Strep A, and then there's the wider communications piece, which is both through central channels but also with partners and into different places, and we're probably not gone far enough yet on that, but it's an active part of our approach to winter and urgent emergency care. And that's it from us.
Thank you very much, Fiona, Sam and Neil. Really, really helpful. So over to everyone, comments and questions, please. And just whilst we wait for anything from the floor, in terms of, Paul coming in.
Thanks, Rhea. It's just a comment really, because you know, from a non-exec point of view, I can only commend the unbelievable amount of work that people have put into doing to getting us to this place, and the incredibly challenging sort of set of circumstances that come together to you know, to face that you're facing. And I suppose my reflection on it is, given that this ICS has only been functioning for a few months really, that, you know, as a group, we took a early decision to really focus on that UEC work, and thank goodness, because we didn't quite know what was going to happen 4 or 5 months, 3 or 4 months down the line. But I think that prep work that you've described, Fiona and Sam and Neil, you know, has been incredibly important in enabling the system to be able to withstand, well, and cope with, you know, pressures that you were predicting, but also a few that you weren't. So, so I suppose the thing that falls out from that will be, when we get a moment to breathe, which is not for a while, I suspect, but when we do get a moment to breathe, to really think about what we've learned from that planning and how we carry that on. And I think the balancing act between you know, the work that we've been doing for this period and the future will be really important as we kind of flip over into hopefully the back end of this at some point early in the middle, or some point in next year. So I think just a reflection really, rather than anything, rather than a specific question, because the quality of the work has been really, really great. Thank you.
And just to add to that, Paul, I was thinking yesterday we were sat with the chief officers that are sat around this virtual table were sat with Neil's team yesterday afternoon, and after what had been their worst day in Frimley Park, not in terms of quality of care, but just the numbers and volumes being the highest they'd ever been in the ED department, and the worry about the experience that was giving patients, and holding our nerve around the framework that we've developed through that work and sticking with the work programme. Neil won't mind me saying, at one level, you know, you were having this real pressure reaction of, oh God, we need to do something else, we need to do something else. And then, and we're not going fast enough on same day access, for example. And then Neil also said, but we've got to stick to the plan and do the work properly. And so holding both of those positions at the same time, and really appreciating how hard that is when you're running emergency services and your staff are run off their feet. I think if we hadn't done that work and we hadn't come together, we wouldn't necessarily been able to held it in quite the same way yesterday. But time will tell through this week if we can hold it for the rest of the week.
Thank you. Really very helpful. So we're going to move now to our performance oversight report, which builds on many of those themes and is the triangulated way we look at finance, people, performance overall, and safety. So Richard Chapman, thank you, Richard, for leading us into this.
Thank you, Chair. So it does indeed build on the conversation that we've just had. Excuse me. So for that.
Oh, you're quite difficult to hear.
I put that out of my way. Okay. So thank you, Chair. Yeah, it does indeed build on the conversation that we've just had. So for that reason, I think I'll start with the operational performance, and there is a published slide. Thank you for putting that on the screen. So urgent emergency care plans for the winter have been produced, and we've just described the work continuing across the system to implement those plans and to begin the implementation of the urgent emergency care strategy work at the same time. But despite that, demand pressures from all areas of the system are extremely high, and there are specific pressures in the most recent weeks, and I'm sure attendees and board members will have seen this in the media, driven by increased paediatric demand. There is a key issue with patient flow through our hospitals. It's a huge challenge. Bed occupancy rates are above sustainable levels, and that's despite the fact that we have had escalation capacity open at the acute sites throughout the whole of the financial year. Those challenges almost inevitably have led to a deterioration in performance within A&E. There are increased numbers of ambulance handover delays, and patients are staying within the emergency department for more than 12 hours in some cases. That escalation capacity is a key driver of the financial performance. So we're reporting a deficit of £24.8 million against planned year-to-date deficit of 2.1 million. The escalation capacity clearly can't be substantively established, so we are paying temporary staff rates at a premium to staff that escalation capacity, which is in excess of 10% of our substantive general and acute capacity, and as I say, has been open all year. In addition to those pressures, we are seeing inflation above that which we had planned for, not only in the areas of energy, but also now increasingly in care package pricing, in pharmaceuticals, and in clinical consumables, as kind of worldwide pressures reflect themselves in prices that the NHS needs to pay. Additional financial controls and reviews of all uncommitted expenditure have been implemented throughout the system to reduce that system deficit, and we will continue to work to live within our financial resources. For system quality, I'm going to hand over chair to Sarah Bellas, who will just take us through that.
Thank you, Chair. I can't seem to get my camera on. I apologise, but I have managed to get myself off mute, so that's helpful. I don't think there's too much more that I need to add. I think Rich and Fiona have done a really good job. I think the single biggest quality issue is the pressures and demands on all of our services, and really being clear that it's bigger than just the A&E department or the hospital. It is about those wider NHS services and the social care services, and that we're extremely concerned about all of them. So that's the point I probably want to make. Thank you, Chair.
Thanks, Sarah. And Caroline, would you like to say something on the workforce at this point?
I think we've covered workforce through others' contributions. I think the only thing to confirm to the board is the assurances that are in place around industrial action. Whilst trusts on our patch aren't directly affected, it's the ripple effect of neighbouring trusts where there are staff on strike, and the planning around the ambulance strike tomorrow in particular. So providing assurance to the board as set out both nationally and regionally. Locally, the assurance calls, which are now daily, reviewing that combination of pressures on services and the planning around particularly the ambulance strike tomorrow, is all in place and effective.
Thanks, Caroline. Happy to take any questions on that, Chair.
Thank you very much, all. I can't see any hands up at the moment, and I know that this call is also being followed by a number of other system and team calls in relation to current pressures. So thank you to the teams that are represented by those participating in today's meeting. If we have no others, I'm going to move us then to Sarah Bellas to take us through the annual emergency preparedness, resilience and response assurance process, please, Sarah.
Priya, I think I'm having the same problems with my camera again.
We can see you, Sarah, don't worry.
Oh, can you? Well, better not.
We can both see and hear you, the best of all worlds. Yeah.
Oh, well, thank you for telling me you can see me, because there's nothing worse than thinking you can't be seen and then you actually can. This really is that third part of the element that we've talked about around that emergency preparedness. This document identifies the process we've been through to look at our assurance process around EPPR. The EPPR assurance process that we conduct is around ourselves, the Frimley and HRCG, our neighbouring organisations that, whilst partly within the ICS, also sit within other ICSs, have been also identified. And you can see that the assessment of all of the organisations is that they're all substantially compliant with the assurance process. There are a few things that need to be completed, and they are all scheduled to be on track to be fully completed by spring next year.
Thank you very much, Sarah. I have no hands up in relation to that. Thank you for updating us. Good. We would now be moving to any questions received in advance from members of the public. We don't have any today. Is there any other business from anyone? And again, I'm getting shakes of the head. So thank you, everyone. And to reiterate, I think the point that Fiona so eloquently opened with, which is the thanks across the system to everybody who is working incredibly hard, and also to the way in which they've been able to understand the anxieties and the real difficulties that our residents and patients across the system are facing, and to be compassionate as they go about providing the very best service that they can in the current circumstances. So to board members and those on the call, a thanks that I hope will ripple out from all the leadership that we've seen, real compassionate leadership in practice, and particularly around things like the MAID event. Fantastic to see that cross-system working, having an impact. So thank you, everybody. This is our final meeting for the calendar year. We are next together in February, and our website keeps everybody updated across the patch in relation to key issues and key messages. So thank you all. Take care.